We'll kick off by looking at some definitions. So we define a diverticulum as an abnormal protrusion of a pouch from the wall of a hollow organ. Diverticular disease refers to the presence of these pouch-like protrusions in the walls of the colon, whereas diverticulitis refers to the state in which there is active inflammation which is associated with the presence of diverticular disease. So as we can see in this picture, there are multiple diverticula present, but also evidence of inflammation, thus making this diverticulitis. An important point to remember, in case you were ever quizzed by a pedantic professor, is that diverticula that are found in diverticular disease are not actually true diverticula. To understand this, we first need to remind ourselves of the layers of the bowel wall. Looking at this simplified cut of the bowel, we can see that the mucosa is the innermost layer, followed by the submucosa. Then continuing outward, we have the muscularis layer, and lastly, we have the serosa. In a true diverticulum, for example, as is the case in Meckel's diverticulum, the outpouching actually consists of all of the layers of the bowel wall, as you can see demonstrated. Whereas, in a diverticulum found in diverticular disease, they usually only involve protrusion of the mucosa and inner bowel wall layers via weaknesses in the muscular layer. And therefore, as the protrusion only involves the innermost layers, we can't refer to this as a true diverticulum. But does this actually make any difference clinically? Well, the honest answer is no, not really. But if you ever get asked by that pedantic professor, you can now tell him that you actually know the difference. Diverticular disease most commonly affects the distal colon, with 50% of cases affecting the sigmoid colon, 40% affecting the descending colon, and 5 to 10% affecting the remaining proximal colon. Diverticula don't occur in the rectum because the tenei coli, or the 3 longitudinal muscle bands that run the full length of the colon, spread out and fuse to form a reinforced outer layer that surrounds the rectum. And it's this reinforced outer layer that prevents protrusions of the diverticular disease from occurring. Diverticula appear to occur as a result of increased colonic intraluminal pressure, which over time appears to encourage external protrusion of the inner colonic layers. If we have a look at this image taken from a colonoscopy, we can see nicely demonstrated a diverticulum viewed from inside the lumen of the colon. Interestingly, in this image, we can actually see a small fecalith, or hard bit of feces, that's become lodged within the diverticulum itself. This is directly relevant to what happens to cause diverticulitis. So let's have a closer look at that. In diverticulitis, the opening of the diverticulum becomes blocked, typically by a fecalith, as we can see here. Subsequently, this obstruction of the diverticulum lumen leads to replication of bacteria and increased mucus secretions within the diverticulum itself. As a result, this causes increasing intraluminal pressure within the diverticulum. This rising pressure results in venous congestion, which in turn leads to the development of ischemia of the wall of the diverticulum, and subsequently perforation. Now, if this perforation is small, then it usually will lead to some inflammation of the colonic wall surrounding it. But typically, the perforation will become sealed, usually by pericolic fat or the omentum. However, in cases where the perforation is large, this usually results in the development of pericolic or pelvic abscesses, or in the most severe cases, can lead to peritonitis and death. If we look at the incidence of diverticular disease, we know that there isn't any significant difference between the sexes. However, it is more common in developed countries, and the theory is that it's related to the Western diet, which is heavy in red meat and protein, and as a result, leads to an increased intraluminal pressure within the colon itself. We know that asymptomatic diverticular disease is very common. Diverticular disease and diverticulitis are predominantly conditions which affect the older population, with 80% of cases occurring in patients who are older than 50. However, if we look at diverticulitis, in the UK alone, it's responsible for almost 80,000 hospital admissions every year, with the vast majority of these involving diverticulitis of the left-sided colon. However, interestingly, in the Southeast Asian population, 75% of cases of diverticulitis occur in the right-sided colon. Now, as to why this is the case, I really don't know. But if anyone watching knows the answer, then please get in touch and let us know. So how does diverticulitis present? Well, typically, the patient complains of crampy abdominal pain that worsens over 24 to 48 hours. Reflecting the fact that diverticular disease can affect any part of the colon, the patient may complain of pain anywhere in the abdomen. However, most commonly, they describe pain in the left iliac fossa. The patient may also describe a change in their bowel habit, as well as the presence of fevers or rigors. And these latter two are consistent with the presence of infection or inflammation. Quite commonly, the patient may experience anorexia, as well as nausea and vomiting. If the patient has inflammation of the colon or an abscess, which is lying next to the urinary bladder, this can sometimes lead to them developing bladder irritation symptoms, which can be very similar to the symptoms that a patient would describe if they had a urinary tract infection. The patient may also complain of PR bleeding with diverticulitis. However, this occurs more commonly in simple diverticular disease, where there isn't any active inflammation. And typically, when this scenario does occur, the patient often describes the absence of any abdominal pain. Thus, if the patient does experience PR bleeding as well as left iliac fossa pain, we should be considering alternative diagnoses, for example, ischemic colitis. In terms of what we can expect to find on examination, the patient may look unwell and usually is in obvious discomfort. In the more severe cases, they may also demonstrate the characteristic features of sepsis. When we examine the patient's abdomen, the patient will typically have pain in their left iliac fossa. If they have sigmoid diverticulitis, which most commonly the patient will have. However, if they have a significant perforation, then they may also have generalized peritonitis and have a rigid abdomen with generalized tenderness. So let's have a look at some key differentials that we should be considering when we assess our patient. As we've already said, we need to remember that whilst diverticulitis most commonly affects the sigmoid colon, it can actually occur at any point along the colon length. And therefore, we should consider it as a differential diagnosis in any patient with any abdominal pain. However, let's divide the abdomen into 3 parts and consider the differentials based on this. So, we have the epigastrium in the upper abdomen, the right iliac fossa, and the left iliac fossa. The key differentials in the upper abdomen and epigastrium include acute or chronic pancreatitis, acute cholecystitis or biliary colic, and gastritis or peptic ulcer disease, which may or may not have perforated. Now looking at the differentials in the right iliac fossa. Well, obviously, we need to consider appendicitis. But also, we have urinary tract infections, terminal ileitis as part of inflammatory bowel disease, perforated cecal malignancy, pelvic inflammatory disease and other gynae pathology, and also, really importantly, in any woman of childbearing age, we always have to consider an ectopic pregnancy. In terms of the main differentials for left iliac fossa pain, they are, as was the case in the right iliac fossa, urinary tract infections, pelvic inflammatory disease or other gynae pathology. Severe constipation is an important non-surgical cause of left iliac fossa pain, and also ectopic pregnancy. However, in older patients and those with cardiovascular disease, we also need to consider ischemic colitis, which most commonly affects the left side of the colon. And additionally, it's really important that in any older patient with left iliac fossa pain, we always have in the back of our mind that they may have a ruptured or expanding abdominal aortic aneurysm. Another important differential diagnosis to consider is a tumour of the colon, and this is especially the case in older patients. What investigations can we do to help confirm our presumed diagnosis? Well, blood tests would be a good place to start. In diverticulitis, as when we investigate any type of abdominal pain, we're going to do a full complement of blood tests. These include FBCs or CBC, renal function, liver function tests, amylase, and CRP. The main abnormalities we would expect to see in diverticulitis would be an elevated white cell count, or leukocytosis, and also a raised CRP. And these would go up in keeping with the presence of inflammation or infection. If our patient is significantly dehydrated as a result of infection or sepsis, we would expect to see some derangement in their renal function which reflects this. And this is principally in the form of a raised urea or a raised creatinine. With regards to amylase and the liver function tests, we wouldn't normally expect these to be significantly raised in diverticulitis. However, it's important that we check them to ensure that there's no pancreatic or biliary cause of our patient's symptoms. An additional blood test to be aware of, and one that's more commonly used in North America and some areas of Europe, rather than the UK, is ESR, or erythrocyte sedimentation rate. Similar to CRP, ESR also becomes elevated in the presence of infection or inflammation, and therefore we would expect it to become elevated in diverticulitis. However, because of the similarities to CRP, in terms of the information that it provides, we tend to either use one or the other, often dependent on the preference of your hospital or country of practice. As well as blood tests, we can also check the patient's urine. We do this to look for any evidence of infection, and also to look for any signs of hematuria, which if present, may indicate the presence of a urinary tract stone. In women of childbearing age, we should also be checking to make sure they aren't pregnant, and also, really importantly, to make sure they don't have an ectopic pregnancy. In terms of imaging, we can do some X-rays, or we can do CTs. In most cases, X-rays aren't really that useful. However, if someone has a significant perforation as a result of their diverticulitis, they may have a pneumoperitoneum. And we should be able to identify this by looking for free air under their diaphragm on their erect chest X-ray. And we can see this nicely demonstrated in this image. Now looking at CTs. As well as showing simple diverticulitis, CT scans are also able to demonstrate some of the complications that may occur, such as abscesses or collections, and also free abdominal air or fluid that may occur with larger perforations. Now, some of you may be thinking, why don't we do a colonoscopy and have a look inside the colon? Well, this is actually something we definitely want to avoid doing, particularly in the acute phase of diverticulitis. As during a colonoscopy, the endoscopist has to distend the colon with air so they can get a better view. Now, obviously, if the patient has a perforated diverticulum, which has somehow managed to seal itself off, the last thing we want to do is inflate that colon. As by inflating the colon, all we do is increase the pressure within the lumen. And as a result, we increase the risk of opening up that perforation again and potentially making the patient much worse. So in a nutshell, in the acute phase of diverticulitis, colonoscopy is a big no-no. If we now have a look at the management of diverticulitis, this tends to be based around the Hinchey classification. The Hinchey classification is a scale of increasing severity, going from mild or simple diverticulitis all the way up to perforation with fecal peritonitis. And the management of patients with diverticulitis varies depending on what Hinchey classification they have. For mild diverticulitis, where there's inflammation in the colon but nothing else, these patients can usually be managed with broad-spectrum antibiotics, analgesia, and if they're significantly dehydrated, then we can admit them for IV fluids. It's actually not uncommon for these patients to be treated in the community without needing to actually be admitted as inpatients. There is some evidence to suggest that these patients may not actually need antibiotics at all, but at present, this is something that hasn't been universally accepted yet. Hinchey 1 refers to when a patient has developed a pericolic abscess, which is basically an abscess adjacent to the colonic wall. Most of the time, we can manage these patients in the same way as we do with mild diverticulitis. So with analgesia, IV fluids, and broad-spectrum antibiotics, again, most likely through the intravenous route. In Hinchey 2, the patient has developed a collection or an abscess that's sitting in their pelvis. In terms of the management of these patients, you can see that there's definitely a pattern, as our initial management is pretty much identical to how we managed the earlier classifications. However, in some cases, particularly if our patient is not improving, we may have to ask our radiology colleagues to perform a percutaneous drainage of the pelvic collection. And by doing this and getting rid of the pus, this usually allows the patient to settle and recover completely. In Hinchey 3, rather than the patient having a contained collection of pus, the patient actually has free pus that's floating around the abdomen. In terms of management, now obviously we're going to give them IV antibiotics, as well as IV fluids and analgesia. If the patient remains relatively well, despite the free abdominal pus, and responds to the above measures, then this may actually be all they need in the acute management of their condition. However, if they're unwell and demonstrating signs of sepsis, or if they fail to respond to antibiotics and IV fluids, then we'll need to take them to the operating theatre for surgical intervention. The aim is going to be to wash out the abdominal cavity and get rid of all that horrible free pus, and achieve control of the surgical source of sepsis, potentially by resection of the diseased segment of colon, which we're going to discuss a bit later on. The last and most severe of the Hinchey classifications is Hinchey 4, which describes when the patient has feces or feculent fluid that's floating around the abdomen, which is really as bad as it sounds. As you can imagine, these patients are really sick and very, very septic. And if they're going to have any chance of surviving at all, they're going to need to undergo an emergency laparotomy, as well as having urgent IV antibiotics, IV fluids, analgesia, and support from the intensive care team. So to summarise the Hinchey classification, if the patient has an abscess, then it's a Hinchey 1 or a Hinchey 2, and we treat these patients with IV antibiotics, plus or minus percutaneous drainage. If our patient has free pus or free faeces, then it's going to be a Hinchey 3 or 4 respectively, and we treat these patients with IV antibiotics and IV fluids. And in the case of Hinchey 3, if they're septic and they fail to settle on non-operative management, then they're going to have surgery and a washout, either open or laparoscopically. And in the case of Hinchey 4, they're going to need an emergency laparotomy. When the patient undergoes a laparotomy, the emergency operation that's most commonly performed in cases of Hinchey 3 and Hinchey 4 is a Hartmann's procedure. This is named after the French surgeon Henri Albert Hartmann, who first described the operation in 1921. Essentially, it involves removal of the affected sigmoid colon, as well as a bit of the rectum, and then bringing out the descending colon and forming an end colostomy. The associated mortality rate that goes along with the Hartmann's procedure is approximately 18%. However, this is more a reflection of how sick these patients are who are having the operation in the first place. Although the stoma that we've created is an end stoma, we can actually perform a reversal of the Hartmann's procedure and join up the remaining colon to the rectal stump. This is usually done at least several months in the future. However, in about 40% of cases, we never actually perform the reversal at all. And this is usually as a result of the patient either not being fit enough for the operation, or because they don't want to undergo another operation at all. In patients who we've successfully managed non-operatively and discharged home, it's important that we follow them up with outpatient investigations of their colon, so either endoscopically in the form of a colonoscopy or flexible sigmoidoscopy, or with imaging in the form of a CT colonography. We usually arrange for these to take place about 6 weeks after the patient's been admitted, as this gives the inflammation a chance to completely settle. The reason we do this follow-up is to make sure that we haven't missed any occult malignancy, as a cancer may have been sitting in the sigmoid colon all along, and may have blocked a diverticulum, causing diverticulitis in the first place. In summary of what we've covered in this tutorial, diverticular disease is a spectrum, ranging from the presence of asymptomatic diverticula to active inflammation, as with diverticulitis. Diverticulitis is very common, and its incidence increases as we get older. Our investigation of choice in the acute phase of diverticulitis is CT, which also allows us to stage the severity of the disease using the Hinchey classification. In uncomplicated cases, we can usually manage these patients conservatively or non-operatively. However, complicated cases often require percutaneous drainage or surgical intervention. And finally, remember that in those patients who are successfully managed with non-operative methods, that they need to be followed up with outpatient investigations to make sure that we completely exclude an occult malignancy.